¿De quién es esto?
You know that you
Okay, no,
so please write down your questions in the application in order to know and manage at the end if we have time.
Ah, que voy a hacer la única que va a hablar en español.
I think first speaker is Dr. Reddy about neuroophthalmology in aesthetic procedure.
So it's very difficult to talk about aesthetics after talking about war, but I'm going to talk to you a little bit about the neurop of aesthetic oculoplastic surgery. Can you load the slide? I see it here, but not there. Same disclosures. Before you cut, measure twice, cut once. In fact, I think you should measure 3 times before you cut once. In our strabismus clinic, we measure 3 times, and if the deviation is stable all 3 times, no cutting. It's very dangerous if you measure once and cut once, and then you have to go back to surgery. So we don't want to have impression, ptosis, planned ptosis repair, and then impression, ptosis recurred, planned second ptosis repair, and then impression, second ptosis repair, recurred, planned neuro-op. You need to have the plan for the neuro-op before you cut. And one of the things that's really important that I have learned in the modern era is let them show you their selfies. Selfie, selfie, selfie. What does it look like in the morning? What does it look like at lunchtime? What does it look at dinner time? Because if you're only measuring them in the morning with your morning appointment, they might look great. Or they might say, you should see what it looks like in the evening, and you'll say this, selfie, selfie, selfie. Because variability and fatigue are the big red flags for myasthenia gravis. The most common referral that we have for recurrent ptosis after a completely successful ptosis repair is myasthenia gravis. So if they say the word variability or fatigability, do not cut. Selfie, selfie, selfie. So we want to see it, what it looks like when they first wake up and when they go to bed. And if it looks like this, don't cut. Refer. Because myasthenia gravis can mimic any painless, pupil-spared, non-proptotic, variable and fatigable ptosis or ophthalmoplegia. So it's always in the differential diagnosis if it's painless, pupil-spared, and non-proptotic. And the problem is, look at 0 seconds here on this lady. She looks like nothing. But after just 10 seconds of looking up and 30 seconds of sustained upgaze, this patient is fatigable. So before you cut, just have them look up and see if it'll fatigue. And you can see with maximum lid closure, those lids aren't closing properly. So that's the second thing you want to do on all of these ptosis people is orbicularis. Test their orbicularis. Because all the benign forms of ptosis, levator dehiscence, do not have orbicularis weakness. So orbicularis weakness, variability and fatigue, those are the main things I want you to take away. Of course, we used to do these Tensilon tests, but Tensilon went away. And so we just have ice test now. We put the ice on there, see if it'll go away. But if it doesn't go away, selfie, selfie, selfie. So here's the ice test. And we're putting on this lady who has bilateral ptosis. And you can see that just after a minute of putting this ice bag, the lid just pops open. So it's just a very quick test for myasthenia gravis, and it doesn't require Tensilon or pyridostigmine or any of those dangerous things. The other thing that you heard about with the plus-minus syndrome was enhancement of ptosis to make pseudo-retraction go away on the other side. This is the same concept, lifting one lid up and then seeing if the other lid falls down. And you're going to do it on the other side as well. You would think this would occur in every form of ptosis from Herring's law, but it is suggestive of myasthenia gravis if they have this enhancement of ptosis. So enhancement of ptosis and orbicularis weakness, those are the two extra things I want you to do before you cut. And you heard a little bit about Botox and fillers from the other speakers. And I just want to mention to you that these things can cause problems. Botox can cause myasthenia gravis and mimic myasthenia gravis, and fillers can blind you. And one of the things that's interesting to me in my practice is the patients don't want to tell me that they have had Botox or fillers. So I'm looking for distinctive signs on their face that say, you know what, you've had the Botox or you've had the filler. And a lot of celebrities in the US have had this. And you heard about giving people back their aesthetics after war. Some of these treatments are taking away their emotional expressivity. You know what I mean when you see their faces. They cannot express the same level and range of emotion that they could before. So your face is derived from primitive pharyngeal gill slits, and those special visceral efferents were designed over time to make you part of the world that you live in. The human experience is driven by facial expression. And if you take this away from people, you might be harming them. Of course, everybody knows what bad plastic surgery looks like. You guys know these are not your patients. And the thing I want you to remember when you're giving the Botox, and you heard some really wonderful talks today about giving Botox, is it can mimic or unmask myasthenia gravis. So if you give the Botox too close to the lid or the extraocular muscles, they might get diplopia and get a ptosis from the treatment. But in all of those patients, before you just say it's the Botox, you still have to work that person up for myasthenia. So I'll say it again so you don't make this mistake. You gave the Botox, it made the ptosis. Yes, it could be the Botox, but that person still needs a workup for myasthenia because the Botox can bring out the myasthenia. And so this is a patient who's published who had ptosis after Botox injection in the right eye, and she got this ptosis. So do you still need to work this up for myasthenia? Yes. And we're going to be lifting that ptotic lid up to look for the enhancement of ptosis. Because if you had given the Botox and you think that's the cause of this ptosis, it will not cause the enhancement and it will not cause orbicularis weakness. So the orbicularis weakness and the enhancement of ptosis and the fatigue still need to be done on the other eye, even if they're only complaining about the Botox ptosis on the eye you injected. And so patients who have had Botox, it'll just go away. So you can reassure these people in addition to making sure it's not myasthenia gravis. And so this is an example of that pseudo plus minus sign. See how the right is retracted. So we're going to lift the left lid up, it'll fall down on the right and prove that's a pseudo retraction. But what if you lift the left eye up and it doesn't go down on the right? That is thyroid and myasthenia. And so the danger zone, as you all know, is injecting too close to the eyebrow. That's the danger zone. So when we see these patients who have ptosis after botulinum toxin injection, I always say, where'd they inject you? And what we're looking for is this kind of like evil queen thing, also known as the Mr. Spock sign. So now that you've seen it, it's kind of obvious in people who have Botox, even though they don't want to tell you they had Botox. So they get this kind of Mr. Spock looking eyebrow, and you can tell who's had Botox in Hollywood because that ain't normal. The other thing you need to know is that the dermal filler can definitely blind you. So I'm glad to hear that you are using the ultrasound to get the vessel, but we still see about 1 or 2 of these every single year. So obviously not everybody is doing it. I don't know why you just don't do it on everyone. And you're going to, of course, pull back on the needle hub to make sure you're not in the artery. And that's because there is this huge network of anastomosing arteries and veins. So anytime you are injecting the filler in the glabella or the forehead, you have risk of retrograde flow of the filler right into the ophthalmic artery and the central retinal artery. And so even if the filler is being injected in the lip or around the nose, it can just go backwards right into the ophthalmic. So it is a retrograde delivery. And if they had just pulled back on the hub, none of this would have happened. The blood would have come back. So I have seen literally videos where people are just injecting like this, and they're not pulling back on the hub. And there are now many cases of sudden acute vision loss after these injections, and the danger zones are forehead and glabella. So here's this patient's puncture wounds. You can see they're in the forehead, and then they got this ptosis and exotropia and had a third nerve palsy. All of that was retrograde filler injection. And this is a fundus photograph from another one of these cases, not mine, of course, but with a central retinal artery occlusion, and you can tell that this has got something in it. It's not just your run-of-the-mill CRAO. If you look at the injection site locations for these dermal fillers causing the vision loss, you can see this is a really dangerous area right here, this glabella and the nasal. So that's where that angular artery is, and then the lip and the dermal fillers and the nasolabial fold, and then 12% in the forehead. So, but glabella, pull back on the hub before you inject anything in the glabella. And that's because these needles are very easy to get into the artery here. And if you just keep injecting, it'll go retrograde right into their eye. So we want to pull back a little bit. Now you can debate whether using a blunter needle and, being more careful on the injection and not pushing too hard. It can get inside your brain, and it can cause ophthalmic artery level occlusions, decimate folds, corneal edema, combined artery and vein occlusions, all have been reported. It can cause multifocal cotton wool spots. It can cause ophthalmic level ischemia that leads to these choroidal level defects. Just horrible things can appear in the eye from these fillers. So in summary, even though it was horrible to see those war pictures, this is bad too. You should be worried about botulinum toxin injection, which can cause myasthenia to come out or can mimic myasthenia. The danger zone is the same place. This is the danger zone, right between the eyes. Vision loss can occur from those fillers, and I look for the Mr. Spock sign and the lack of facial expression for patients who don't want to tell me, or they don't want to tell me in front of the person they're with, that they've had Botox. Get the records and find out what happened to the person. Measure twice, cut once. I thank you for your time and attention.
Please, Dr. Lee. So, Dr. Lee, unfortunately, cannot stay to the discussion afterwards. And I want to ask you, make profit that you are here. So, for me, one of the most difficult things I do a lot of congenital ptosis, and I met a lot of kids with the suspicion of myasthenia. And for me, from my point of view, it's one of the most difficult things to have a proper diagnosis of myasthenia gravis, at least on kids. Can you tell us, please, any key points to what are the key points for the diagnosis on a patient for myasthenia gravis, please?
Yeah, so it's the order of operations is symptoms. The symptoms you're listening for are painless, variable and fatigable, alternating, bilateral. So that's the history. The exam, you have to do the pupil. Painless, pupil spared, non-proptotic, but if it's any pattern of ophthalmoplegia or ptosis, even in a kid, you should be thinking about myasthenia. First line laboratory testing is anti-acetylcholine receptor antibodies. Second line testing is a different antibody called MuSK, and then there are third line antibodies. But if you're trying to get to third line antibodies, you need a neurologist to help you. And then a CAT scan of the chest for thymoma. Neurology can do single fiber EMG. Regular EMGs don't really find it, but sometimes they get lucky. But really, you need to get a neurologist to help you. So the diagnosis of myasthenia is difficult. You can do the easy things, get the history document, show the history, variable, fatigable, document there's no pupil involvement and no other cause, and then refer. Thanks for having me.
Next speaker, my friend John Bareno from Colombia, will speak beyond the eyelid, integrate endoscopic malar lift into oculofacial rejuvenation.
Good afternoon to everyone. Luigi, it's such a pleasure being here with you, return to Italy and share knowledge to you. I'm John Bareno. I'm a oculoplastic based in Colombia, and over the few past years I've been working and integrating different techniques, surgery techniques, just to improve my outcomes, especially in facial rejuvenation. So today I want to talk to you about a very important concept that is usually often determines the results in the surgery, the negative vector, and how the midface influences outcomes in eyelid surgery. Now, the real problem is that today that we continue to treat the periorbital region as a local entity. However, we are not evaluating aging as a global facial process. Technically, our surgeries are correct, but they are definitely not, they're not truly complete in terms of rejuvenation. We are treating the eyelid, but we are not treating the cast. So, in other words, we have to remember the malar complex. Together with the zygoma, it provides and defines the mid-face projection support, and when the system loses the support direction, the impact directly is expressed in the periorbital region. And this region has multiple layers. We have the bony component with the zygomatic bone providing a structural projection. We have the muscular component, including the zygomatics major and minor. And we have the fat component, which provides volume and contour. And all these together contribute to the facial support. Now, during aging, we observe that we call a negative vector, where there is a downward and medial descent of the tissues, and this directly affects the appearance of the periorbital region. So if we only treat the eyelids, we are not treating the consequence. We are treating the consequence, but we are not treating the cause. So aging is not a local process. Aging is a vector-driven process. Therefore, treatment should be limited to local correction. It requires restoring support, direction, and tension of the entire midface. So the question here is, where should we redirect the displaced vector? And the answer is clear. We must restore the original direction that has been lost, lifting the tissues in an oblique and superlateral direction. So let me show you. Can you click on the video, please? That's it. Okay. Let me show you briefly how I approach this surgery. I like to begin with the precise markings. I use different colors just to create a mental map of the structures that I need to respect. I mark the original ligament, the orbital rim, the superior border or the zygoma, and the key landmarks like the sentinel vein and the frontal branch of the facial nerve. We can see here, there is an usual measure to do this. This is lateral to the orbital rim. I like just to mark this area, the key mark that I used to do with the radial seine, and I usually mark over the 2 centimeters above the eyebrow just to make a path of the frontal branch of the facial nerve. Once, then I choose an area behind the hairline just to make an incision close to the orbital ligament. I like to go down just to find the deep temporal fascia. And now just trying to dissecate all this area and trying to create a pocket where we're going to work. So I go directly to the deep fascia, and then I take this sector, a blunt dissector, just softly. I try to elevate all these above the deep temporal fascia. I go to the orbital rim. Really easy to do it, really easy to make this pocket. I try to respect all the structures. You have to be in the right plane, not to make a lesion of the frontal branch. I try to release the orbital ligament. That depends on the patient. Some patients once they brown elevated, and if you want to do it, I mean, you need to release this orbital ligament. Sometimes we don't do it. If the patient doesn't need you to elevate the eyebrow, you just stop and not try to release this ligament. We just reach the orbital rim, try to liberate all this area. This release may be done very carefully to avoid, like I say, the orbital nerve injury. So after releasing these ligaments, we will see another view. This is the way we release it. Really easy to do it. I mean, this is an endoscopic view. We try to release all this area. We try to release with the sector this lateral orbital rim, and we go to the orbital rim, the orbital ligament, and release all this tissue. This is what the plastic surgeons call like endoscopic blepharoplasty. When they release all the attachments that we have for the orbital rim, they say they do this kind of surgery. Blepharoplasty, endoscopic blepharoplasty. So we just release all the tissue just to get a movement, a right movement of the eyebrow if we need it. And you need to do this just to get a higher position of the eyebrow laterally. So after this, I like to create a blunt dissection to the mirror to the mid-face, creating a tunnel between the sentinel vein and the orbital rim. We're doing this with a blunt dissector. We go in this area where we are entering a space down this mass. We are going to the deep area tissues. We are opening a tunnel, and you go to the mid-face, basically. You go till you can reach very medial on the mid-face. We are liberating all the cheek. You can see here. And once you are there, we prepare the needle and place a couple of traction sutures. And the key here is to identify the correct traction of the points. The traction is progressive and vector-based. We start from the cheek, the middle of the cheek. We're moving to lateral to orbital canthus, and then from median to lateral canthus. And then finally, we go to the temporal area just to try to raise the tail of the eyebrow. Now this is the way we prepare the needle. We use non-absorbable sutures like Mercilin 40. We try just to get a bite of the SNAS on the deep tissues, and once you just pass the suture, you can make a traction of the tissue, and you can see it here. We can make it according to the design we did. Sometimes we are using 3 stitches, often till 5, but we are doing in certain points that we plan before just to do it. Like, the middle of the cheek could be the lateral orbicularis, the lateral canthus, and over the retinaculus too. So we can do this. We just put the sutures, get a traction of the tissue, and this is critical. To use non-absorbable sutures, because the biggest problem of lifting procedures is recurrence due to absorbable sutures. Over time, tissues descend again. So permanent sutures here provide more stable results and longer lasting outcomes. So we can see how we pass the needle. So we can do it. You have to learn this movement. You have to prepare the needle definitely, because the curve of the needle is not enough just to do it endoscopically. So you need to learn how to make a special curve with it. And you have to train your hand just to take the sensibility, just to pinch just a little bit of the tissue. You can mark outside. You can elevate the tissue. You can make some pressure on it, and you can see, or even use a needle just to see where the suture need to be passed. So you can see it here. We are almost at the temporal area. We are very thin. We need to take a bite very thin, because if you got a lot of tissue, you will have some depression in the skin. So you have to take care. You have to train about this. Just remember, it's not the same curve the needle. So this is what we want to do, just to raise the tissues and You can see the cheek, how we can raise it. You can design what kind of elevation do you want to have. This is another patient with the same kind of traction, certain traction, and we all fix it on the temporal area. This is the PO of the patients. We use a lot of bandage and types. Usually, I say to the patient that day 4, we remove the tapes and reassess. We wait for 1 month without significant improvement, and we wait three months. You just have to say to the patient, we need 3 months just to get the final results. So this is the evolution. Pictures just taken by the same patient. These are some of the using of the tape that I said to you. This is the patient, and continue. And this is the evolution of the appearance of the patient, where finally we get these results. So, what are the indications for this technique? And these are clinical results before and after. After 3 months, the same in another photo. And basically, we have this indication. In facial rejuvenation, we can use it for mid-face descent and volume loss, malar flattening, and deep nasolabial folds. And in case of reconstruction, we can use it in lower eyelid mid-face junction deformity, post-blepharoplastic complications, and eyelid retraction or ectropia. So, the conclusion of this technique is we approach the mid-face. We are not just performing a surgical procedure, we are restoring the vector, structure, and harmony of the face. Thank you very much.
Thank you very much, John. Next speaker is Dr. Paez, and he will talk about, let me see. Yeah, mid-face.
Well, good afternoon. Thank you so much to Dr. Luigi Colangelo for this invitation. I'm grateful for being here with all of you, and this beautiful place is being a dream, you know. These lectures, I wanted to approach more philosophical way than a clinical way, but I show you several videos done these several techniques that you understand that the mid-face is a place that the oculoplastic surgeons have to be more efficient, because the more tools that we have to approach the face, best result that what we have. This is the picture that we show in all our lectures, that the 3 things that the face have is less bone with the years. All the soft tissues came down with the age, and the volume of the fat is descend and decrease. And we need to treat 3-dimensionally this problem, because if we leave only the face, we have a strange look and with no volume. But when we try we treat the face 3-dimensionally, we support the tissues and voluminize it. If we only apport volume to the face, we have a pillow face and ugly results. These 2 levels of knowledge is that we are like the oculoplastic need to understand the view of all the tools that we have to learn to approach the face, not only the periocular region. Also, we need to learn the mid-face and the lower face to harmonize all the anatomical face tissues. And the question that I give to you is, what do you want? This one Daniel Paez with only a few tools to resolve a problem in the face It's not only in aesthetics, also the reconstructive approach of the face, of the eyelids. It's involved the mid face and the lower face. And the problem of the eyebrows is also a frontalis problem. The problem of the upper eyelids is also a problem of the brow and the frontalis. And the problem of the lower eyelids is also a problem of the mid-face. And if you have all these tools to manage the face, like techniques of blepharoplasty, techniques of to approach mid-face, techniques in lipofilling, like microfat, nanofat, biostimulators, lasers, endoscopic techniques. You have all the tools to approach the better way a face. And it's our goal learn about all these tools that we have to get a better result with our patients. I choose this way, you know. It's so much tools that we can have, like oculoplastic surgeons, that for better results. The knowledge, the limited knowledge that we have when we, with our early years of practice, is only to resolve some kind of problems. But if we learn about the complex of these tissues, like Barreño says, the malar regions is so much layers of problems. The malar edema, the malar festoons is so much complex to resolve, and we need so much tools to resolve these problems. And we need to focus in the eyelids, upper and lower eyelids. We need to focus in the deep structures. If we don't deep plane reposition, we don't have a very good result, you know, or less longer results. We need to provide our patients better results and longer results. The technology is always created for have an easy job, you know, or a better approach to the tissues. And the lasers is a good tool to improve the skin. Everything, forget the last of the tissues, that is the skin. Skin is the most important tissue for resolve a laxity and the pass of the time. And we need not only do the technology, but also learn the beautiful science about drug delivery. It's a very good tool to improve the skin. The power of the fat is, we all know that the stem cells in the fat is like a miracle, you know? Because I say always, I'm not fat, I'm full of skin cells, you know? And this is the most beautiful tissue in the world, and it's free for the patient. It's autologous, you know? If you are good to extract the fat, process the fat, and inject it very well, you have good results and very low cost, you know? And it's an invitation that if you don't know how to process fat and do the lipofilling, is a very good technique to use now for our patients, and have the good results. This is a clinic case that we have patients that are very laxity face with melasma and all the problems that we have in a face. We have AI reconstruction in the anatomy, and we have a little video that approach no endoscopic about endoscopic for the hairline. I approach this patient from the subciliary incision. That we approach the SUF, and we performs a technique that laser and endo laser for direct view. We put this on focus laser in these tissues for shrink these tissues. I put you in a video, in the next video. We reposition the SUF and all the tissues from subciliary incision, and we have to estrange the mid-face, and also do CO2 laser and microneedle radiofrequency, and make microfat and nanofat. These all techniques together is that we call multi-level surgery that don't miss any level of anatomy of the face. You go to the bone to reposition the tissues, and you don't forget the skin, it's the most superficial layer. Let me pass another video, but this result doesn't view 1 month or 3 months. You need to improve the quality skin with IPL, with treatments, and you have better result like this. This is the other video that I want to show you. It's not the festoon, it's the ptosis, it's the laxity of the upper eyelid, the lower eyelid, the fold of the frontalis, and I do the same technique. I approach this patient from the subciliary incision, and this is the most the tissue that loose, and we reposition all the tissues. But first, we with on focus laser. This is a Emera from DECA, and we shrink these tissues that we have so much empty space in this region. We shot around the ligament, around the skin, with no burning. We need to improve this tissue with vaporization and not carbonization. It's a very artisanal way to say, but we need to give the tissue the heat for tense the ligaments, you know. And let me show you that after we suture all the down tissues to the orbital rim. This, I want to show you this. Is all that several sutures that we reposition the mid face to the orbital rim. And this is the result from 1 year of this patient. Treat the melasma and treat with the surgery, and all with the tools that we have to improve their skin. This is what I'm talking about. The results of the mid face reflect the beauty of the eyes. You know, if you don't reposition the mid face, you don't have these beautiful eyes to combine to the rest of the face. And men have to these problems and results. This is the mid face reposition. Men's too. And thank you very much.
Thank you very much, Daniel. Next speaker, Susana Matayoshi, will speak about Asian ABL phlebotomy. Yes.
Oops. Okay. Thank you, Luigi, again, and Daniel Vaio also. I'm speak today for Asian blepharoplasty for non-Asian surgeons. I don't know why these patients, I have a lot of Asian patients. I don't know why, but look, this case, this 77 years old lady that came because she wanted to remove the excess skin. This was conservative surgery, but after surgery, she said, "This is not me." She did not recognize her face after surgery. It was a minor surgery. What is happening? What the patient want? Patient want to improve the appearance, be more beautiful, be more attractive, but without drastic changes. And today, I will talk about 5 issues in Asian blepharoplasty. First, incision height, where to place. Second, create an upper eyelid crease. After, I will talk about fat removal, epicanthus, edema, and scar. Some differences between Caucasian, Western eyelids versus Eastern Asian eyelids. The lower septum insertion, that turning eyelid more bulky, and low or absence crease. Where to place the incision? The lower incision than Western eyelid incision. Between 6 or 7, I think it's a good point. And the patient choose the height higher or lower. That can see in this scheme. And eyelid crease, I think it's most important in this kind of surgery. We produce an indentation suture to show the platform, pretarsal platform. And we do this kind of surgery, taking skin, levator, and skin, using 6 or Prolene suture. But this kind of technique, I think we can cause levator disinsertion or asymmetry between tarsal plates. So I am using a less invasive technique. It's not a new technique. We can see in this paper, Lu paper, and I will show this technique. Can you play the video, please? After incision, we do some grooves in orbital part, 4 or 5 grooves. These grooves, we take a suture. It's a Prolene 7.0.
Recording in progress.
Oh, why? No, it's a 7.0 Prolene suture. And this groove is important to bury this suture inside orbicularis. It's a 4 or 5, you choose, and many knots, because Prolene is such a suture. And it's partial tarsal suture. We must do to see that no damage to tarsal surface. And after we do the skin, superficial orbicularis, and skin to improve this indentation. Okay, you can see in this schema. So this kind of surgery, it's a conservative blepharoplasty upper and lower blepharoplasty with a crease like 6 millimeters. Another point that I want to talk to you is about fat removal. It's obvious that we avoid the central pocket fat to not cause an older look. But in an Asian patient, it's frequent a more lateral fat around lacrimal gland. So carefully, you need to resect this lateral fat also. Another question is about eccanthus. We need to avoid to increase eccanthus, and so the incision begins 4 millimeters away from medial commissure, like this. And edema and scar is some concern to this kind of patient because the skin is thicker and edema is more long-lasting. The scar, you don't be afraid with scar because the initial hyperemia takes 3 or 6 months to vanish. So it's not keloid, it's not hypertrophic scar. And we can see here the results of natural Asian-looking eyelids. And with blepharoplasty, eyes look bigger, useful, and more attractive. But we must not confound with westernization of Asian eyelids, because Asian blepharoplasty is not about changing to Caucasian eyelids, but influencers are changing the standard of beauty, and we don't know the future of beauty patterns like this influencer create some kind of new species like elfish face trend or multiple cosmetic Chinese influencer Abby Wu that I don't know. I think it's some kind of changes, and we don't know the future, but it's my opinion. Thank you very much.
Thank you. Next speaker is Natalia. She is upper and lower blepharoplasty, restructuring, fat repositioning, and modern support techniques. Natalia.
Olá, buenas tardes. Soy Natalia Cassis de Brasil. Muchas gracias, Luigi, por la invitación y felicitaciones por este magnífico evento. Voy a hablar español. What is written in red is Spanish, and what is written in black is English. Then, top 10 acertos y aprendizajes. La blefaroplastia que hago hoy no es la misma de ayer. Esta foi minha primeira blefaroplastia depois que finalizei mi fellow, de 2 anos. Então, aqui para mostrar como a experiência vamos melhorando cada vez mais. Nesse tempo eu pensava que era só sacar, sacar, sacar. Vou dar 10 tips. Tip número 1. A primeira coisa que vejo em pacientes é assimetria em la exposição de plataforma tarsal. Pode ser causada por assimetria de surco, Tosis ou assimetria de supercílio. O que eu hago? Párpado que tem menor exposição. Eu hago sutura de brasier unilateral, resecção maior de grasa e eu hago suco ligeiramente mais alto. Não hago suco assimétrico, pero ligeiramente mais alto. Em párpado com maior exposição, párpado mais hundido, eu hago transposição de grasa, se necessário, hago correção de tosis, se necessário, e surco ligeiramente mais baixo. Não hace milagro, pero essa diferença de suco dá uma impressão de melhorar a simetria. E sempre hablo ao paciente, não vai se ver 100% simétrico, pero vas a melhorar. Isto é muito importante. Todo o que disse ao paciente antes da cirurgia é uma explicação. Todo o que disse depois se converte em justificação. Por isso, eu estou muito tempo com o paciente antes da cirurgia, explicando detalhes. Transposição de grasa superior, eu hago com moderação, não hago sempre, depois vou falar por quê. Eu hago essa técnica de IMAX, sempre a ser a marcação onde há A-frame. Então, para mim, o mais importante em transposição, tanto superior quanto inferior, é sempre deixar a grasa muito bem pediculada. Para mim, é o secreto. Atualmente estou fazendo com prolene, antes fazia com Vicril e tinha muita inflamação, às vezes pus na pele, então estou preferindo fazer com prolene. Pacientes que existe transposição, paciente feliz. Paciente que existe transposição, feliz. Paciente com transposição que não se quedou satisfeita. Por isso, hoje, eu hago a transposição superior com moderação. Por quê? Esta paciente gostava de párpados hundidos. Ela não queria rellenar párpados superiores. Então, eu não hago em todos. Tipo número 3, me gusta cauterizar Miller. Quando o paciente não tem tanta tosse, pero tem o farol barro, me gusta cauterizar el Miller. Este tipo eu hago em todas as minhas primeiras consultas. É um tipo de marketing. Isto compro em AliExpress ou Mercado Livre em Brasil. É como simula uma blefaroplastia superior. É muito simples, pero encanta os pacientes. Tipo número 4. Blefaroplastia inferior transcutânea versus blefaroplastia inferior transconjuntival. Eu hago 60% transcutânea, 40% transconjuntival. A transcutânea me encanta. Tem sim mais complicações, pero tenho resultados estéticos melhores. E a transconjuntival, menos complicações. Esta é a diapositiva mais importante da charla. Se querem, tomem uma foto. Todos os pacientes que vou fazer blefaroplastia inferior, eu evaluo esses 8 itens. Vector negativo, hendidura negativa, escleroshow, laxitude tarso ligamentar, se tem fenômeno de Bell ausente ou presente, triângulo escleral lateral mais grande, eversão do borde palpebral e se tem blefaroplastia prévia. Se o paciente insiste em uma blefaroplastia há 20 anos, está bem, agora tem mais pele para sacar, eu sou mais conservadora, porque será uma segunda denervação. Então, este é triângulo escleral lateral. Eu sempre observei esse triângulo e quando fui escrever meu livro, em muitas literaturas habla sobre triângulo escleral lateral. Quanto mais grande, mais risco de retracção. E eversão del borde. Paciente número 1 tem a linha d'água mais invertida. Nesses pacientes eu não saco pele, porque tenta ter retracção. Este é um tipo também que eu hago muitos cursos em design e sempre a mano ela tende a barrar lateral. Então, sempre trato de subir e não barrar. A eliminação de pele pode ser seu melhor aliado ou seu pior inimigo. Quanto mais experiência tenho, menos pele eu saco. Eu sempre, ao final da cirurgia, eu saco fotos da pele que tiro. Por quê? Porque quando comparo o resultado com minha cirurgia, o que existe, eu consigo estar sempre hoje melhor do que fui ayer. E sempre pensem, se falta pele, serão ao menos 6 meses para resolver o problema. Se sobra pele, em 5 minutos pode resolvê-lo com um pinte. Aprender de la experiência de los demás é menos doloroso do que de la própria, acreditem. Então, aqui alguns antes e depois, outros. E todos esses casos eu saquei muito pouca pele. Eu hago muito laser e hago também peeling TCA. Agora sobre transposição de grasa inferior, eu prefiro ser transcutânea, para mim é muito mais fácil e o resultado se vê mais bonito. Quando que eu hago transposição transconjuntival? Quando tem 2 ou mais daqueles riesgos, daqueles 8 riesgos de retracções. Então, eu sempre deixar a grasa bem peliculada, eu hago supraperiosteal, Prolene 5 doble agulha, eu salgo com agulha 15 milímetros abaixo de Tirtró, quito ponto com 15 dias. A decisão transponer ou não transponer não é tão fácil, pero eu nunca me arrependi de transponer uma grasa, pero já me arrependi de não transponer. Então, se eu tenho dúvida, eu transpongo. Pacientes que têm malária hipoplásico, sempre transpongo. Pacientes como estas, não há necessidade de transponer. E uma paciente como essa, se não vai a transponer ou não vai a ser lipofilling, é melhor que não se opere. Ok? Transpongo. E esta paciente, é curioso, eu transpus ojo esquerdo e não transpus ojo direito, pela anatomia que teria antes. Aqui então vou mostrar como que hago essa blefaroplastia transconjuntival. Essa primeira incisão para mim é a mais importante. Eu hago sempre anterior à carúncula e sigo a segunda arcada vascular, onde os vasos estão espiralados, a 6-7 milímetros de margem. E sigo sempre 3 passos. Sempre procurar o borde orbitário, de dança do cotonete e 3, pressionar o globo. Em algum desses 3 passos, vas encontrar a grasa. Para quem está começando, quando empecé a ser blefaroplastia inferior, para mim o mais difícil era encontrar a grasa. Me havia perdida em párpado inferior. Então, sempre com esses 3 passos, encontrar o borde, dança do cotonete. Juliano é um italiano que estuvo comigo, ele sempre não falava português, pero dança do cotonete, ele aprendeu a falar. E 3, pressão no globo. Aqui é como eu hago sempre a ser a manobra de Gaimastre, a manobra inversa do ilustrador de sapatos. Transcutânea, mesmo que não vou a ser transposição, eu sempre hago a liberação de ligamento retentor orbitário, e mesmo em transconjuntival. E aqui como eu hago a transcutânea. Eu vou despegando pele de orbicular por 10 milímetros, pero percebam que eu não deixo a pele tão delgada, eu sempre deixo um pouco de orbicular pegado em la pele. Vou por 10 milímetros. Quando eu chego a 10 milímetros, eu vou profundizando até chegar em borde orbitário. Hago toda a liberação. Mesmo se não vou a ser transposição, eu hago liberação de ligamento retentor. Agora tenho hecho muito lipofilling, pero mesmo que hago lipofilling, eu hago transposição de grasa. Para mim, a primeira opção sempre é transponer a grasa. Então, aqui, deixar a grasa bem pediculada. Estive em congresso em Colômbia há um mês e discutimos sobre onde passar a sutura em la grasa. Me gusta sempre passar em terço distal. Há muita gente que passa em terço proximal. Me gusta passar em terço distal e sair com a agulha 15 milímetros abaixo de Tirtró. Eu vou passar porque temos muito conteúdo. Em alguns casos, eu aprendi com Jeremia Tal, eu não hago sutura, solamente ponho na grasa, também se vê muito bem. Aqui, foramen infraorbitário está 1 milímetro de borde, 1 centímetro de borde, 1 milímetro medial a pupila. Las cantopéxias. Me encanta a cantopexia transcantal. Então, sempre passar a esquina. Eu hago com Prolene 5, Vicrio 5 ou Vicrio 6. Depende de caso. Depende de quanto que quero que fique. Depende se tem hendidura negativa. Então, eu hago muito personalizada esta cantopexia. Se quero subir mais, eu entro com os pontos um pouco mais distantes um de outro. Esta cantopexia... Consegue soltar? Pexia de orbicular. Eu hago em quase todos os casos. Mesmo quando hago transconjuntival, me gusta a cantopexia de orbicular. Aqui onde passo os pontos, em azul é onde passo a pexia de orbicular e em amarillo onde passo transcantal. E aqui arriba onde hago a sutura de brasier. 7 sulfilites eu tenho hecho cada vez menos porque tuve alguns edemas prolongados. Então, é uma técnica com buenos resultados? Sim, pero também tem mais problemas. Lá inferior, eu tenho seguido a ser lo básico bem hecho. Eu tenho hecho cada vez menos em blefaroplastia inferior, cada vez menos coisas com buenos resultados, pacientes felizes e eu feliz. Aqui alguns antes e depois. Me gusta muito tratar a pele com laser e com peeling TCA. 9 estamos acabando. Sempre tenho em minha clínica triancinolona com 5-fluoracil. Sempre hago 1 para 1. Em muitos casos, se está repuxando, se tem algum incômodo, em retracções que recebo de outros médicos, antes de operar, sempre hago 3 sessões de triancinolona com 5-fluoracil. Aqui, liberando os retentores, também vai bem. Menos é mais, principalmente em la blefaroplastia inferior. E para finalizar, para lidar com a estética, ser um bom cirurgião e fazer um bom trabalho não é suficiente. Você pode ter pacientes com excelentes resultados, pero insatisfeitos. O paciente problemático dá sinais. É melhor perdê-los que encontrá-los. Sempre crê em tu intuição. Elija a quem não operarás. Paciente que habla mal de outros profissionais, paciente que quer garantia exata de quanto por cento vai melhorar, paciente mal educado com a secretária e educado com o médico ou mal educado com ambos, paciente que pergunta, que passa se tem um paro cardíaco em la cirurgia? Eu digo, não vai passar porque não vou te operar. Paciente que já hizo consulta com 10 cirurgianos e te errou, paciente que depois de ver vídeos quer ensinar ao médico, e paciente que se queja de esperar 10 minutos em la sala de espera. Essa é minha clínica em Brasil, estão todos invitados a conhecê-la. Muitas graças.
Thank you, Natalia. Next speaker is Cecilia Rodriguez about Pro Lifting 2.0 beyond traditional blepharoplasty.
Hello. Good afternoon. To continue about the talks, I think we can all agree that just blepharoplasty is not gonna get us what we really want. So I'm gonna talk about the brows. The brows are responsible for our emotions. They also are responsible for the singularity of our faces, and they express our personality. Also, they are a trend of fashion, and they are responsible in part for our beauty. So when we see patients in our other clinics, the most frequent complaint is looking sad and tired. So let's see what happens with this patient. So this patient has already had a blepharoplasty. So do you think this is a good result and the patient is happy? She's not really happy because she didn't get what she wanted, which is to feel like, to see herself like she feels. So the first thing that I would say is when we're looking at our patients, don't forget about the brow. Brow ptosis is a result in general because of aging. When we age, we lose bone density, we lose elasticity, and also the muscles that pull the brow up and the muscles that pull it down lose their equilibrium. So there are many brow lift techniques, as they've already been discussing many of these. transblepharoplasty browpexy, direct brow lift, subcutaneous brow lift, endoscopic brow lift, mid-forehead brow lift, and coronal brow lift. So you gotta choose what's best for your patient. We're gonna talk a little bit about the browpexy. I use it in most of my surgeries. It doesn't really lift your brow, but it helps you with avoiding the descent of the brow when you do your blepharoplasty. Also, it helps you with asymmetries. Let's take a look at this patient. So when I saw this patient, I saw that her right eyebrow was lower than left one. So when I did her blepharoplasty and her browpexy, I only did it on the right side. So afterwards, you see that the right side is okay, but the left side has gone down. So you need to take that into account in your surgeries. So we're gonna see what we really do. I usually do my surgeries with laser. We do an incision about 10 millimeters on the top of the border. Then we dissect. When we are dissecting, we need to make sure that it's very deep so that we avoid dimplings. Then we place our suture. Right now I'm placing a 5-0 Prolink suture. I'm not using Vibrio anymore. And then you need to lift the roof. So before I used to really put a needle and check. Right now I just see the fat and lift it. I check if it lifts, and then I just make sure that there's no dimpling. It's something that doesn't add up to the time of your surgery and really gives you very nice results. So this is a young patient, 7 days after her surgery. I did the browpexy on the right eye. So you can see a little bit of fullness in that area. It's very subtle, but I think it helps. This is another patient. I asked her for some pictures before the surgery, some old pictures, and she always had her brows in a low position. So if I did anything else, she would have been changed. So I just did a browpexy, and I think we can achieve what we want, which is a very natural result. The next technique is the subcutaneous brow lift. I use it when there's a thin eyebrow, when the patient doesn't wear makeup, when she's not going to get a micropigmentation, and in patients that are very, very afraid of noticeable scars. So what you can do it behind or on the front of the hairline. You make your marks. It's all, in general, I do it in this shape so that it makes it less noticeable. Then you have to dissect all the way to the border in a very superficial way so that you avoid any damages. And then when you place your sutures, in this one it is important to do some kind of fixation to the periosteum, because otherwise the result lasts less time. So I think it gives us a very natural result, but sometimes I'll find that in time it goes down. Also, you need to advise the patients that they're going to have some numbness in the area for about 6 months. This is another technique that I use a lot in my clinic. I use direct brow lift when there is severe lateral descent. Also, when I see asymmetries. It's very good in men when they have thick eyebrows. Also in women that have micropigmentation or are leaning to do that after the surgery. It works very nicely in women who have bangs. So after the surgery, it's almost invisible. And the thing that you need to ask the patients is that if they have a good scar, because if they have keloid, you have to stay away from the surgery. So this is the way that I generally do it. Even though I use laser in my clinic, I do this one with a cold steel because I don't want to damage the hair. You can design the thing that the lift according to what you want to do. So you can change the shape of the incision. You need to put some Vicryl sutures, and then you need to do it in 2 planes. and then you can place your prolene suture. What is important about this surgery is to avoid tension when you're closing, because if you avoid tension and you invert your borders, you're going to have a very nice scar. So when I was doing this talk, I was reading if there is anything new, and I found this article. This article talks about a transection and a suspension of the orbicularis oculi muscle in an attempt to for the results to last longer. So I thought it was very, very nice, and I'm going to try it. These are some results. This is the brow lift only on the left side. This is on both sides, always combined with blepharoplasty. So what we see in patients is a very natural result, and it even looks like we did something in the forehead. It's just that she's resting her forehead because she doesn't have the tension anymore. So very subtle results. And what scares us about the direct brow lift? The scars. So the most important thing is to try to avoid scars. How can you do it? Number one is to avoid the tension. I think that's the most important thing. I usually use silicone patches afterwards for about a month. Also, I usually use Botox to avoid movement. And also when somebody is taking a bit long to get a good scar, I have some devices that help me, like Resurface and the CO2 laser resurfacing. So I think the key message would be, you need to think about the eyelids and the brows like a unit. Brow lift is personalized. It depends on the patient needs and the surgeon's experience. All photographs are very useful to plan your surgery because our aim is natural results. And our objective is always to recover expression while keeping the essence of the patient. So thank you, Luigi, for organizing this Congress. We get to see so many friends, and we have Daniel in our heart. I hope he is happy wherever he is. Thank you very much.
Thank you very much, Cecilia. Next speaker is Jose Ron Montes. Is Biostimulators, Friends of Fall in Facial Aesthetics.
Yes, thank you. Bueno, estoy impresionado. I'm very impressed of the amount of people that are here. So I'm humble, honored to be here. Luigi, thank you so much for this invitation. Ravelo has been amazing. I've been here for a whole week. So, thank you, gracias. So my disclosure is that I have served as a trainer, speaker, consultant, and clinical investigator for Allergan AbbVie, not honor, MERS and Galderma. Two of these companies have a biostimulant agent in their portfolio, and the third one is in the process of bringing one to the market. So it's very appealing to have products that through your own immune system could create collagen, elastin, and some other extracellular matrix components. By typing the magic words, facial rejuvenation and biostimulation into Google, you'll discover products designed to restore, through the power of your immune system, tissues. I introduced PLLA. Remember, PLLA is a Sculptra. I introduced this in Puerto Rico. I've been using this for 17 years. And for the purpose of this presentation, remember that I reconstitute the products with 8 cc's of water and 2 cc's of plain Lido 1%. Once PLLA is injected, a controlled inflammation response begins, led by fibroblasts and macrophages, with collagen and elastin as the byproducts. During this process, we anticipate and hope that fibroblasts will take over macrophages. One of the most interesting findings today, and I know this slide might be a little bit confusing, but just remember this. Biostimulating agents upregulate genes involved in tissue modulation. RNA sequencing has shown that PLLA upregulate genes related to adipocyte modulation. I started using Radius even before its FDA approval in the US, and at that time we were only focused on volume. Later, we all know that we use the product mostly for regenerative capabilities, and that's why the product is so popular today. CAHA, or Radius calcium hydroxyl apatite microspheres suspended in carboxyl metal cellulose create immediate volume. So that's nice, right? You get volume, rapid. We all want rapid results. But subsequently, the volume stays there, but the particles induce a collagen building response, prolonging improvement even after the initial carrier dissipates. This graph may look complex. I want you, for now, to look to the blue line here. This blue line marks the dilution of the product. We all use CAHA or Radius as a biostimulant agent in a non-label manner. That means that we add volume to the product, to the syringe, either normal saline solution, lidocaine. Once you dilute the product to 1:1, that means that you put 1.5 of dilutant, the product immediately, you see the graph goes down. This is the lifting capability, the G prime, lost completely. But look now at the red line. At that same dilution, the red line goes up. And what that measures? The collagen reproduction capability. So that means that a 1:1 dilution makes sense for facial injections in terms of restoring tissues but not creating volume. Both Galderma and MERS, they have been publishing results arguing that their products is less inflammatory than the other product. But they agree in one thing. Both products do produce collagen, so they do live up to the expectations. Their effectiveness, though, ultimately depends on the injector and the patient. In terms, the third group of products are the PRP and PRF, and the only thing that I'll mention is that we use these as adjuvants to other procedures, microneedling, lasers, etc. And about synthetic products that last, that are permanent, I don't recommend them, I don't use them, I have zero experience with them. So, biostimulators are meaningless without the vision of the injector and the patient's goal. But what about hyaluronic acids, right? There is evidence suggesting a modest role of neocollagenesis in HA injections. However, new evidence also suggests that hyaluronic acids may remain in tissues for an extended period. This is especially true in the periocular area. This prolonged presence may lead to unintended product accumulation with repeated treatments in the same area, creating a more complex management solution. I was pointing to Ana Duarte, who is sitting front row here, that this morning the patients you show you were doing the mid-facelift. Some of them had products, and she told me, yes, many of them had a lot of products. And that's through years, no? We are all familiar with the facial overfill syndrome, and for me, the early stages of this phenomenon can be detected when the natural soft indentation of the infraorbital halo disappears, resulting in smaller looking eyes. And this is important for those that we're talking about fat reposition. You have to take this into consideration as well. So there's no doubt for anyone here, you all saw it, that for oculoplastic practitioners like ourselves, the eyes are the focal point of facial rejuvenation. So let's get into the nitty-gritty. In our toolbox, we need hyaluronic acids, I'm clear, and biostimulant agents. In my clinical practice, hyaluronic acids are usually injected into very specific anatomical sites, while biostimulators are used for framing and more facial volume restoration and also skin quality. For the periocular area, please look here carefully. Upper eyelid and roof, I do agree that HAs or hyaluronic acids are what you should be injecting. But for the lower lid and mid-face transition, this is the core of my talk. And I'm so happy that John, Danielle, Natalia, Anna, everyone was talking about the mid-face. Because there, the eyes are the focal point of rejuvenation. And if you want to go further inside, is in that transition between the lower lid and the mid-face. In that transition, you have been using HAs, right? Hyaluronic acids. Yep. How many people here have been using biostimulant agents for that transition zone? Vigo here, Russia there, good. And Portugal and Turkey, great. So mostly in general. So our goal in periocular rejuvenation, and by the way, that's me when I was 7 years old, and I was a shallow orbit patient. No negative vector, shallow orbit. So it's clear that our goal is to soften that transition between the lower lid and the mid-face. That's why the companies has come up with fillers for the tear trough. 3 have been FDA approved in the States, and now 2 more are coming in their way. But oculoplastic surgeons, like ourselves, we are doing less tear trough injections, less infraorbital injections. In some patients, to conceal the tear trough, you may do HAs. We are clear. But only if you follow the perfect balance formula. You need the ideal patient, you need the right product, and you need the right technique. For a successful and predictable tear trough injections, we need this type of patient. A definite infraorbital demarcation or a true bona fide tear trough. No fat or little fat showing the lower lid, and most important, good skin tone. Most of these patients has congenital tear trough. King Charles III, he has inherited many privileges, including sovereign immunity and states like Balmoral. But of all the, and I learned today through Vita Ismaili that he's from St. John's Hospital Board. So, but of all his bequests, those emblematic tear troughs certainly stand out. So, dark circles, individuals with hyperpigmentation in the upper or lower lid, patients with too much fat, and patients who has been injected with hyaluronic acid somewhere in the infraorbital area are not good patients to inject. Initially, the results seem acceptable, but over time, a bluish edema becomes apparent. Surprisingly, some patients and doctors still consider this result good. This patient had a change for the teardrop, and this is a patient of mine, and the after picture was taken 4 years later. This is my first crucial remark. Remember, hyaluronic acid tend to remain for years. 4 years at the periocular zone. That's why Dr. Ana Duarte, when she was talking about lid retraction, injection, either in the upper or lower lid with HA, she meant it. You inject that and the patient will keep them forever. That, of course, covers the lid retraction, but the edema will stay there forever too. So for now, let's focus on that ideal patient, and I assure you that if you see 40 patients a day in your clinic, maybe one will have the fissures to be injected at the teardrop. You want a product that repels water and integrates well. We don't want a product that may remain forever. And this is it, the ideal patient, a man, thick skin, a really deep infraorbital halo, no fat in the lower lid. I do this just one entry point, usually aligned with the medial iris limbus. I use a cannula that is 27 gauge 1 inch, and I do my entry point according to the size of my cannula. And of course, we advocate that the material must be placed supraperiosteally. But who knows, when you are there, you are not seeing the periosteum, but you feel it. So palpation must be top of your list with your non-dominant hand and with your cannula. And then through that same entry point, you do the lateral aspect. And you will see that I always use my vacation hand to make sure that I'm on the place that I want my injectable, and also to accommodate my product. This is the result. So it's clear for you that for those few patients that you will see in your practice, this is the ideal patient for teardrop. Now this is what I wanted to show. Most patients that complain of looking tired, they don't know what they want to specifically tell you, but they will point towards the mid-face. And you will see that patients will present with infraorbital halo, present with orbital or lower lid fat prolapse, but skin elasticity loss or skin laxity, some damage, eyelid fluid, long-standing edema, orbicularis hyperactivity, or festoons. There are many things playing on these patients. I start using, and I want to talk about my male composition of patients. In my practice, I see about 20% are male patients. And most of them, what happened? The monitor there is gone. You know, you can do the speakers, you can twist your chair. Should I wait? Okay. Anyway, I was talking about male patients. Like female patients, they look for Botox. Second, for eyelid surgery. That's what they look for. If they get into fillers, they only want fillers for the transition of the lower lid and the mid-face. Why? Because for some reason, and that's the subject for study, I do see more negative vector patients, male patients than female patients. I don't know if that's true for you, Anna. True for you, Natalia? Yes, they all agree. So, for these patients, I do biostimulant agents, and this is what I want to show you, and this will change the way you practice. Okay, as I said before, this is my landmark. Inferior orbital ring, orbital retaining ligament, and zygomaticus cutaneous ligament. Of course, everything lateral to the infraorbital bundle. aligned with the medial iris pupil. I'll inject in vectors. I see Augusto, this is not painful. I see your face. I inject, my hand is my GPS for safety, is at the inferior orbital rim. The needle is reaching just to the orbital retaining ligament. And what I'm doing is depositing PLLA or biostimulatory agent at what structure is there. Of course, I'm using the bone, but it's basically the suborbiculary oculi fat pads. I'm trying to recreate those. And the gradual collagen deposition after approximately 3 sessions, I do 3 sessions, spare between 4 to 6 weeks. But look how that smooth out the topography of the infraorbital midface transition, and in many cases improve malar projection and bizygomatic width. On this patient, ligaments effacement, and here a better malar projection. This is a patient that due to systemic medical condition was reluctant to surgery. A biostimulant agent was injected at the maxilla, as you saw, to compensate for the lower lid fat prolapse. And this is after 4 sessions. Remember, this is without surgery. In conclusion, consider biostimulant agents such as PLLA to smooth out the topography of the lower lid cheek transition. Biostimulant agents have a tremendous potential in your practice. This is Luigi and me. I think this was, I don't remember, Jose Luis, this was in 2009 or something like that here in Amalfi. So I want to thank you all for your attention. I want to mention that my technique was published this past 6 months ago at the journals JDD. So you can write me and I can give you the publication with the technique and with the results after more than 2,000 cases. Thank you so much.
Thank you, Mr. Raul. Let's start the rapid fire session. I asked to the speakers to be in both in 2 volumes, so the second one can be in the second place, and in order to have more time. And I have to tell you that Dr. Emilio Serra has we have a problem with the edition of the program, and Emiliano is not in the program, but Emiliano will give us another speak at the end of this session. Doctora
Skovorodnikova Inna from Russia.
So what?
Skovorodnikova.
I'm very sorry. Let's go. And this is Dr. Marcela.
Hello, I'm glad to be here, and I would like my job about thread implantation of the midface as preparation for the eyelid blepharoplasty. How can I choose? Age-related changes of low eyelid and midface are linked, and when we examine the patient who plans blepharoplasty, we pay attention to the low eyelids fat pads, prominence of the nasolacrimal and mid-cheek grooves, prominence of the nasolabial fold, and displacement of the midface fat pads. Low eyelid is like a sail stretching between 2 points, medial and lateral contours. Zygomatic and cheek areas are movable, support for the sail. And this is why we suggest to stabilize midface prior to correct the low eyelid. The first stage of correction is thread implantation in midface area. In our practice, we use different threads designed for cheek and mid-face area. As a result, the soothe and soft tissue are restored in low eyelid contour is improved. The projection of mid-cheek and nasolacrimal grooves are reduced. Threads are absorbable and are made of the copolymer of lactide with caprolactone. We use two techniques, and technique Y, we use a 36 centimeters long spiked thread. Every 6 centimeters, the direction of the spikes is changed. The thread inserts through one stab incision, forming the shape of a leaf. It is possible to place several leaf-shaped construction in the single application. It is an easy technique for oculoplastics to perform, and it only takes about 2 minutes to place each leaf. This construction allows to shift and elevate the soft tissue of the midface, not towards the direction of the incision, but supporting the cheek and providing volume. Technique 2. For this technique, we used the thread 60 centimeters long, and this is used in patients with thicker skin and more developed subcutaneous fat. This thread is placed in the mid-face, fixing it at the superficial layer of the temporal fascia. Stage 2, it's a surgical low blepharoplasty. It is stage surgery work with tissues that are already corrected in the more favorable anatomical position. This reduces considerably the risk of low eyelid malposition after blepharoplasty. Takeaway message. A good result in low eyelid blepharoplasty sometimes is not only about the eyes. Eyes plus mid-face are responsible for the younger look. It is an easy technique and a very useful tool for oculoplastics in order to improve the results of a low eyelid blepharoplasty. Mid-face support helps to reduce post-surgical complications. Thank you for your time and attention.
Good afternoon, everyone. I want to say thank you to Luigi to give me the chance to stay here in this beautiful portrait, which is Ravello, and to give me the chance to meet so many friends of mine that are based in all over the world. So today I'm going to talk about how to treat the tear trough with the hyaluronic acid, a step-by-step approach. As we all know, the eyes reflect health, vitality, and emotions, which is why the periocular area remains one of the main aesthetic concerns in patients of all ages. The tear trough is a particularly challenging area to treat. To achieve optimal and natural results, I follow the ATP protocol, which stands for Anatomy, Technique, and Product. We must first master facial anatomy to distinguish ligament, vessels, and compartments. Once analyzed, we select the price technique, whether in needle or cannula, and a product with specific rheological properties. Before any treatment, a careful clinical assessment is essential to confirm that the patient is a suitable candidate, reduce the risk of complication, and align expectation. In this patient, for example, a few simple manual tests help us assess lower eyelid zone, rule out lymphatic stasis, and determine whether the deformity is mainly due to volume deficiency. Assessment of the orbital vector is an important part of clinical evaluation. A positive orbital vector is generally associated with a more favorable anatomy for the tear trough correction, while a negative vector suggests reduced mid-face support and may require mid-face treatment first. Patient selection is one of the most important factors for achieving successful outcomes. Poor indication, instead, should be avoided, particularly in patients with severe eyelid bags, marked skin laxity, fluid retention, or malar edema. The ideal candidate is a patient with a true tear trough deformity, good skin quality, no significant excess skin, and little or no tendency to edema. About the technique, the tear trough is a particularly challenging area to treat, as I mentioned before. It's because it's one of the first facial areas patients notice. Expectations are usually high, and the skin is extremely thin, so even small irregularities may become visible. This treatment can be performed with either a cannula or needle. Personally, I prefer a cannula with microboluses placed in the supraperiosteal plane. My golden rules are simple. The patient should be treated in the upright position, not supine, and the treatment is preferably performed with a 25G for 40 ml cannula, injecting in the suborbicularis or supraperiosteal plane. In the neutral or negative vector, lateral support should be addressed first, as this may improve the tear trough and directly and reduce the amount of filler that could be medially. Product selection is crucial in tear trough treatment. Specific HA fillers are better suited to the infraorbital region area, thanks to their radiological profile. I prefer 15 mg/ml hybrid HA, combining cross-linked and non-cross-linked change. Its light consistency and low hygroscopicity help minimize edema to this treatment. Thank you.
Dr. Mansour.
Yeah. My slide. Thank you for the opportunity to present today. I have no financial disclosures. The aim of this presentation is to report a case of a patient with excessive fasciitis of her left upper eyelid who achieved full functional and cosmetic recovery. This 80-year-old lady was referred for management of her left upper eyelid defect, presented with skin necrosis, lagostalmos, keratitis, and ptosis. The patient reported a recent episode of severe orbital cellulitis for which she had been hospitalized 1 month prior. The diagnosis of necrotizing fasciitis of her left upper eyelid was made. On examination, best corrected visual acuity was 20/25 in her right eye and counting fingers at 1 foot in the left eye. The only available image is shown, demonstrating a left medial orbital wall fracture. CT scans could not be retrieved from the hospital system. However, the patient did bring a report stating swelling and hematoma of the soft tissues in the left periorbital region and left temporal fossa. Surgical debridement of necrotic tissue was performed, and samples were sent for microbiological culture and antibiotic susceptibility testing. Clinical management was achieved with periodic disinfection with topical rifamycin 1% spray and the Derman ointment. Systemic antibiotics were used. Clindamycin was used in this case, following her last regimen used upon discharge after hospitalization. The patient referred having a facial trauma after a fall from standing height, and that was the reason for her hospitalization. Sorry, I forgot to say that. This is the rifamycin and the topical ointment use. This is the healing process, and this is the 2 months follow-up with full functional and cosmetic recovery. Erythromycin ointment was applied for her keratitis, and gadifloxacin 0.5% drops were used for a developing corneal ulcer. This is the 16 months follow-up. And this is a video, can we play the video? Demonstrating her full closure of the eyes. Insulin drops were used for an ulcer that could not be healed, so we used insulin drops. So in conclusion, periorbital necrotizing fasciitis can lead to severe visual loss, eyelid dysfunction, and severe disfigurement, highlighting and even mortality, highlighting the importance of urgent intervention. Clinical management can be achieved through prompt surgical debridement, systemic antibiotics, and local wound care. Sometimes, and evitating the necessity for grafting, as in this case. These are my references, and this is the picture we took 2013 with Dr. Daniel Weil, who was my professor and mentor and led my path in oculoplastics. Thank you very much.
Emiliano, let's go.
Okay, good afternoon. So, can I start? Yes? No yet. Okay. Today I'm going to talk about something that we use every day, but that we often underestimate. We are, oculoplastic surgeons. We are very precise. We work in millimeters. We talk about symmetry, very tiny difference. But guess what? When we take our photos, we are not that precise. We change the lighting, we change the angle of the patients, and we compare the photograph as if were they the same. What do you think? This is the surgical result, or is just a different photographic technique? Another example, plenty of these on social media. Is this a very good surgical result, or the result has been improved with different lighting technique? What do you think? Photography is not neutral. It directly affects how we evaluate, how we see, how we judge our patients. And we use every day, in every aspect of our practice. So the important question here is how we do it correctly. So do you think we need this in our practice? Professional equipment? Guess what? No. It's not about having pro equipment or having the last iPhone. It's just simple method. And by method, I mean taking the photos in the same way every time. Consistent photos. Repeatable under the same condition. That is what makes our photos useful clinically. If we change the light, the appreciation of the lower eyelid bags is different. If we change the position of the chin, the scleral show is different. The same, we change the angle, the ptosis is different. You change expression. I asked this patient to elevate the brows. You can't see that because she has Botox, but doing that, the ptosis is different also. The distance, this is a very common mistake. We use the 1x for the photos. That's wrong. The perspective is completely wrong. So, when we see these photos, it's not always changes on the patient. It's just different photographic techniques. So, the important concept here is taking the photos under the same condition always. And how we do that? It's just controlling these 5 key variables. And we can do that with a very basic protocol. I'm not going to talking about technical photography and technical words. It's just a very simple method you can apply at your office. So, 5 points. First one, use diffuse, consistent lighting. You can do that with a photographic camera and a flash like this. I'm bouncing the flash backwards or to the ceiling. But if you don't use a camera and use your phone, you can use a ring light. But use always the same light. That's very important. Don't use direct flash. Don't use the light from the ceiling. And ambient light also is variable. The light coming from the window is not always the same. Okay? Second point, same head position. In frontal views, no up tilts, no down tilts, no side rotations, lens always on the lens. It's pretty simple. Number 3, sorry, it's still the second point. In oblique views, a very useful tip is to ask the patient to turn the head until the nose lies with the cheek. Third one, same distance, as I told you. I think the sweet spot is between 3 and 4. Neutral expression, ask the patient not to smile, okay? Very simple. And full face, you know, you can crop later, no problem. So the key point is here is correct photos we can repeat. So you can use these 5 simple points. It's very simple at any office, and that's all. And if you want to download the full guide, you can scan the QR code. Thank you very much. For those of you who want to go a little bit deeper, I can talk to you about the camera setup I use in my office. Thank you.
Okay. So thank you all for being here. Let's do a little shift. Let's talk about something completely non-medical right now. And having 4 minutes to talk about mental health is like the challenge of a lifetime, but challenge accepted. So what's happening right now? Why are doctors having such a big amount of burnout? Because for us, there's a hidden cost of perfection. People want precision, beauty, perfection, but at what cost is this happening? So what is burnout in surgery? It's emotional exhaustion, but just not like being tired. It's really exhaustion, depersonalization, which means detachment and loss of satisfaction. And this for me is the big part. It's losing joy in what we do. I think for most of us, doing surgery is our passion. And the moment we start losing joy in this, then it's a big red flag for us, right? Why is this happening? Because we work in a results-driven field. Like, our results are visible, are subjective. We are under constant evaluation. Social media is not helping. Patients what we do is really, really visible. It's not like visual acuity or stuff like that. So what happens with the new patient? The new patient, I don't know if your patients are like mine, but they come completely influenced by social media. They know what they want. They give you their plans for what they need. They need a cantopexy, they need a fat transposition. They come with so much information that it's exhausting even for us. And they come with really unrealistic demands. They want fast results, they want painless results, they want no complications, and they look for the doctor that can assure them 100% of these 3, which is unrealistic at best. And why are some surgeons more vulnerable? And this is something that really bothers me. You know, I have my best friend, he lives in Uruguay, and every time I call him with a complication, he's like, man up, Sharon, you're a surgeon, bad things happen, just face them and solve them. And I ask, like, can I cry a little bit before solving them? You know, why is he so strong and why am I so vulnerable? And the reason is completely personality driven. So I give you all perfectionists here a big hug, because us overachievers are the ones that suffer the most. There's a big emotional burden. Complications get to feel personal. I don't know you, but every time a patient gets complicated, we take it home and we sleep with a complicated case or unhappy patients. This satisfaction stays with us. There's one unhappy patient that weighs way much more than 1,000 happy patients, and we have to remember this. And then we start self-doubting ourselves, so the imposter syndrome starts breaking up. And there's the culture problem. We have to be doctors, we're surgeons, we have to man up, we have to be strong, we have to be in control. We chose this. And nobody talks about it. Talking about mental health for us is like super weird. I'm the only one talking about this here, and probably in the last top 10 meetings I've assisted. And why it matters? Because it affects our performance, it affects our personal life outside the OR, and the patient care. So we need to start redefining success. It's not perfection, it's safety, it's ethics, and it's integrity. And this is the most important slide for here. What can we do? We need to treat ourselves personally and have a support system. So personally, we need to normalize mental health conversation, start setting boundaries, and select our patients carefully. And we have to have a support system. We have to have mentors, colleagues, open conversations. I know Toria hates me every time I call him with a complication, but it is what it is. He's part of my biggest support group I have, so we have to have big support systems. And this picture sums it all up. You know how patients get to choose the doctors that treats them? Well, us doctors have to have the ability to choose the patients we want to treat. Because it's so important to have empathy with the patient and the doctor, and to connect, and to have patients that require like decent expectations. So behind every perfect result, there's a surgeon under pressure, and taking care of the surgeon is part of taking care of the patient. Thank you so much.
Thank you very much for every speaker. I think we have little time to discuss something. Does anyone of you any questions about the speakers?
Dr. Cecilia Luna?
Yes.
You talk about Botox after transcutaneous brow lift. Is it that doing that because it can improve your scar, but it can put down your brow? How do you deal with that? Do you talk to the patients? Micro Botox?
Acércate. Vale.
Hi. The way I do Botox in this kind of patients is I inject Botox in the depressors. I don't inject the forehead, and that's it.
That's it.
So, any other question?
I would like to ask, Daniel, if the new techniques or the new microecographies have changed the way you use the hyaluronic acid, the fillers.
I used hyaluronic acid for many years and have a very good experience with this. But when you approach the mid-phase, you know that the hyaluronic acid sometimes is a very problem, you know, that because this hyaluronic acid expand the tissues and accumulate water. It's 100% is from you inject 1 cc and you over the time you have an inflammatory reaction, and when you reposition the mid-phase and put fat, the mix of the fat and hyaluronic acid is not a good yes. And you, with the outcomes of ecography, it's a very good tool to know what is the substance in the face when you operating room. You go to the operating room, and all my patients, I do an ecography and mapping all the face, because sometimes the patients say to you, I don't inject nothing in my face, but in Venezuela, over the years, we inject sometimes like PMMA and silicones and so many substances. It's a good tool with, like Jose Ramon says, good patients, select your patient, select your product, and good techniques is a very good tool, but you need to know when you dissolve it.
I have a question. Como tienes el micrófono, I have a question for you. For you and for anyone that do lipofilling, fat grafting, nanografting. So when you do multi-layer, multiple procedures on the same patient, how do you analyze the result? So how do you know what is working, what is not working, what is deserved, what is not deserved?
I approach the face like area proportions, like a mathematical proportion, and I ask the patient that what he wants or what she wants. And so many years to harmonize the face with injectables let me be a better person with fat grafting. But fat grafting is sometimes is unpredictable, and that the way that I approach the fat grafting is I only extracted the fat 1.5 or 2 hours after we re-inject, because the cells is died in the process. But I have several techniques that approach from nasolabial folds, and I put in layers. So put in the bone, put in the bone and the muscle. But the microfat is so when you extract with the cannula of the donor, it's not possibility that and you get in the correct plane, it's not possibility to granuloma, but the quantity of the I inject, I decide in the moment. It's like an artistic way to approach. It's not always is a mathematic answer. It's an artistic way to approach the fat, and I look the patient and I say, okay, this is enough for me, and I expect the 30% of reabsorption the fat.
Professor Raúl, what to say?
Okay. In Spanish or in English or in Italian?
In Italiano.
In Russian.
Italiano.
Okay, I'll put my money in here for anyone.
If you have a patient who had a facelift, an endoscopic brow lift, a mid facelift, fillers, microneedling, biostimulant agents, peelings, topicals, whatever, and you could segment, give points to what gives the patient the wow effect, is what you do in the eyelids, the upper cleft or the lower cleft. So if the patients could have at the assessment the opportunity to see, okay, this is how you're gonna look after your upper left or your ptosis correction, for children as well, or your lower lid, this is how you're gonna look. This is how you're gonna look after that with a mid-face, with a brow lift, with microneedling, with fillers and with needles. Most likely they will say, I'll stay with the first one.
This is dangerous.
Huh?
This is dangerous.
That's what I think. I mean, I think that the potential of the eyelids, I mean, you show it in your talk. It's a life-changing experience for a kid that has had a droopy lid since he was born and cannot stand it after 3-4 years old when he knows about social interactions. But in adults, it's the same. It's the eyelid what gives the real wow effect. So I think we are lucky and fortunate that we are the top specialists in eyelid surgery, period.
Thank you.
Yes, because Lelio has an answer for the myasthenia gravis, and I want to hear. I got him just in the beginning. Sorry.
Before, practically speaking about myasthenia gravis, is quite a difficult field. I have some experience with Graves, because you know that Graves patient in 10% of the cases has also myasthenia gravis, and very often it's difficult to make a proper diagnosis. So we have to start with saying that myasthenia gravis could be of two types. You may have a systemic myasthenia or an ocular myasthenia. In the case of systemic myasthenia, you may have the autoantibodies positive in only 50% of the cases. So the other 50% are perfectly, well, normal in terms of alteration of the autoimmunity. The ocular myasthenia is always antibodies negative. So don't look for antibodies when you are suspecting that there is ocular myasthenia. The diagnosis can be done with single fiber, let's say, electromyography. But the single fiber electromyography is extremely difficult to be performed, and normally is not performed on the muscle that you want to test, but only on the orbicularis. Since for neurologists it is a very sensible way of diagnosis, they think that if the orbicularis is positive, also your suspect muscle, for instance the levator, is also positive. But it's not like that. You should open the conjunctiva and stick, for instance, in the medial rectus, your single fiber sonde. This is possible, but has practical problems. Why practical problems? Because the machine, the electromyographer, is extremely sensible, and if you bring the machine into the operating room, is influenced by all the instruments that are present in the room. So you are not really recording from the single fiber, but you are recording the let's say the electromagnetism that is in the operating room. There is a possibility, a way out. You have to own a Faraday gate. So you have to put the electromyographer under a gate of Faraday, and this is very difficult to have in the context of the hospital. What you can do is to operate the patient in a storage room. That is exactly what I'm doing, with personal risk, because there is not sufficient sterility, but just to open the conjunctiva and stick a needle in the muscle, you may do that. All this is very difficult and operator dependent, so very often you don't have reliable data. Which is the way out? The way out is one ex juvantibus criteria. You give steroids if you suspect ocular myasthenia, steroid only, and you might have an answer. Or you give steroids and the period of stigmina if you suspect a systemic involvement. In the case you suspect a systemic involvement, or you have evidence with positive autoantibodies, you need also to do a mediastinum X-ray or CT scan, spiral CT, because very often this patient has a thymoma, so they are at risk for life. The other let's say, practically situation is, and this is probably the most easy way of acting when you suspect apoptosis driven by myasthenia, is the exercise test. You start asking the patient looking up and down till when you see that, I don't know, for 15 millimeter of levator function became in time 5. At that point you have make your diagnosis. And the same is with deduction, no? Right, left, up, down, and then you see that there is, with the pen light, there is a gradual decrease of power of that muscle. In this case, you can make your presumptive diagnosis, and then you can confirm with an ex juvantibus criteria by giving them the medicine you think is convenient. But it's quite difficult deal with myasthenia.
So I'm happy because I'm not the only one that for me is difficult. It's difficult for anyone. I think it's very, very difficult for anyone. Thank you, lady, for the explanation.
Okay, I have a question for Jose Raul. And I want to say thank you for the session. It was very interesting to all the speakers. But Jose Raul, I want to ask you about the biostimulators. We know that they have a great role on the collagen and replication. But now that the plane lifting is getting more and more common, and we're seeing better results with it, it is a problem for patients who have had these biostimulators because it interferes a little bit with the dissection. So what is your approach for patients that might be a good candidate in the long term, or the short term, or medium term for a deep plane lifting and biostimulator use?
Okay, the rule number one, as you saw, biostimulant agents, the way I use them mostly are in the mid-phase, right at the maxilla, between the orbital vitelline ligament and the zygomaticus cutaneous ligament. There is no smash lift, there is no deep plane lift that has to go there. Okay, this is a deep